All right, welcome to Three Plastic Surgeons and a Microphone, where we have a very special guest today, Dr. Amy Alderman, fellow resident back at University of Michigan, back where we train for plastic surgery. Before we get to Amy, I would like to just do our ritual disclaimer. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based on the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something in this show. And with that, I would like, Sal, would you like to introduce Dr. Amy Alderman for us?
Sure. Amy, so good to see you.
Thank you for having me, guys. It's good to see y'all again.
So Amy Alderman is an exceptional plastic surgeon. I've known her for many, many, many years. She was my chief resident at the University of Michigan. And Amy, I don't know if you remember this, but the first month of June when I started my residency, you were my senior resident and you took me through my first operation, which was an appendectomy. The first time I scrubbed at the University of Michigan. So we go back a long way.
That's a frightening thought, me taking you through an appendectomy. How'd the patient do?
She did great. She did great. And so Amy ended up becoming an attending at the University of Michigan and was exceptionally well published. And, you know, you had several research projects going at the time, and you achieved, my understanding, the rank of professor, correct?
That is correct.
Fantastic. And then Amy, you know, missed the deep south from the chilling cold of Michigan and decided to relocate to the lovely city of Atlanta, Georgia, and Amy was actually looking for a position when I was a fellow there. So we communicated quite a bit about Atlanta and ended up just starting a wonderful, vibrant, and exceptionally busy private practice in the city of Atlanta. And now she's still quoted for a lot of the research that she's done in breast reconstruction at the University of Michigan. And it's just a top-notch person as well as a exceptional plastic surgeon. So Amy, thanks so much for joining us today. How's everything going for you in Atlanta these days?
Oh, it's good. You know, we're still, it's still warm down here. So the COVID cases are still kind of at bay a bit compared to, I think, some of y'all where it's a little bit colder. But it's good. It's crazy. Ever since we closed the operating room for about a month last March when COVID really hit. And then when we figured out a way to test patients and we opened back up, we haven't gone a day without operating. I don't think it's been nuts. I think everybody's sitting at home and they're either doing projects in their house or projects on their cells, and they realize they can do a lot of breast and body cosmetic procedures and still be on their business Zoom call the next day. So.
So, Amy, tell us a little bit about your practice. Kind of what's it like? What are you doing? What's your favorite type of case?
Yeah. So when I was with these guys at Michigan, I did all breast reconstruction. In fact, I think one of my last micro cases might have been with you, Sal. So it was probably pretty memorable. So it's nice to be back in Atlanta, where I am from the South. And my practice now is 100% cosmetic. It's probably 95% breast and body. My bread and butter procedures are my mommy makeovers, breast reductions, breast lifts, tummy tucks, lipo. So that's kind of my professional life. We built a new office about 2.5 years ago. So we have our own operating room, and it's nice because we don't have to be subject to the local hospital in regards to when we can operate and when we can't. And so it allows a lot of freedom in regards to taking care of patients and trying to meet their scheduling needs also.
That's great. You know, one of the main reasons, not only because of your pedigree, but one of the main reasons we wanted you to join us is to tell us a little bit about, or a lot about, what it's like to train as a female plastic surgeon and what it's like to be a female plastic surgeon now in practice. So maybe tell us, you know, what first drew you to plastic surgery?
Well, I have a little bit of unusual startup because I always knew I wanted to be a physician. I grew up with my grandmother, and she was an invalid. She had emphysema. So I always was in and out of the hospital, and I knew I wanted to go into medicine. And one of my really good friends that I used to ride horses with growing up, her dad was a plastic surgeon in Nashville. And he let me go into the operating room with him when I was a junior in high school. And as soon as I walked into the OR, it was this magical experience. And I said, this is what I have to do. I was lucky enough that he introduced me to Dr. Louis Vasquez, who, if you're a plastic surgeon, you know who Dr. Vasquez is. He's at UAB. And he's one of the pioneers of our modern day plastic surgery. And he's such a sweet man. He let me spend every summer with him at the end of high school and college, just following him around. So I just wanted to be whatever he was. He's a very amazing, innovative surgeon. And unfortunately, my friend's father, who got me into plastics, just passed away 2 weekends ago. So it's thinking about him a lot right now. But, I wanted to go into plastics, not because I was a man or a woman. That gender didn't really play a role. It's just what I absolutely love. And it's who I am. It's not really a job. It's a part of me. They did tell me, early on that it would be challenging to have work-life balance. But you know what? I would like to think that's a challenge, whether you're a man or a woman. You guys are all fathers, and y'all want to spend time with your kids. And so it's really, how do you balance work and your family life? And I think hopefully the challenges are the same for men and women.
So, we just recently in the media, they've started this new series, Dr. 90210, and this is an extension of a previous reality TV show. But the interesting thing is, it's now all about. There's 4 board certified female plastic surgeons. Are you familiar with the show, Amy?
I'm not. I'm too busy watching TV.
Work-life balance. So, one of the interesting things about the show is it's 4 board-certified plastic surgeons, all female plastic surgeons, and they all have different types of practices. And it's just kind of interesting to follow them around and see kind of what makes them tick. And so, the reason I bring this up is what keeps driving you, to spur your practice and be successful, and kind of what just makes you tick here.
Well, I would like to say one thing. I would like for us all just to be considered amazing plastic surgeons. And I'm not quite sure why we have to distinguish ourselves by our gender. I think, I'm no different than you guys. And I'm not sure why there needs to be a special show just because we're women. I think the key is that you're the best that you can be at your profession. And I don't want a leg up because I'm a woman, and I don't want to be discriminated because I'm a woman. I want my opportunities because I do the best I can do, and it should be based on the person, not on the gender. So what makes me tick? I mean, this is just what I love doing. There's nothing better than to be in the operating room. I just love to operate. Now, if I could operate and not have to do clinic, that would be even better. But I think we all love to operate, right? So my practice is nice because my practice is mostly, 90% of my patients have very similar lives as me. Majority of my patients are women. Majority are either professional women or stay-at-home moms. So I can relate to them on some level. I don't have a practice that's I don't have a large male patient population. And that kind of makes sense because I think a male patient would probably rather go to a male plastic surgeon if he has some insecurities. And so I think the patients that come to me, they come to me because they think will do the best for them locally here in Atlanta. And then, but it's easy for me because I can relate to them in regards to kind of their issues and insecurities that we all have after we have kids and the changes that happen to our bodies.
I was going to ask you, Amy, obviously medicine is a reflection of society, and society has its own biases, which we saw growing up and training in medicine, whether it was your ethnicity, whether it was your religion sometimes even, or whether it was your gender, depending on who you worked with or who was training you. I think it's certainly better now, and we definitely have better perspectives now in 2020 than, say, when we were coming up through training. Do you feel that there were challenges just based on your gender alone? And do you feel like that's no longer the case in medicine, or do you still think that those issues are still there, if they were or are?
Well, I think a lot of my challenges occurred when I was on faculty at Michigan, because I was the only woman out of the 13, and I did delay having kids until I was on faculty. So I had 2 kids pretty quickly back to back. And so, my challenges were figuring out how to have the clinical schedule that we had at Michigan, make the faculty meetings every week at night, make the journal clubs, and take care of all the calls. So I would calculate usually about 10 nights out of the month I wouldn't make it home to see my 2 babies. So that's why I left academics. I always wanted to be in academics. I still consider myself an academic. I still am involved with a lot of our professional meetings, and on the board of directors for the American Board of Plastic Surgery. So I'm still involved, but I don't know how it is now in academics, but that was my biggest challenge, is how do I do my day job and figure out how to get home to see my 2 kids. It's definitely easier in private practice because now I have control of when I want to end my day and what my obligations are after work. So
I will say that there are a number of women faculty members at Michigan in plastic surgery. I just wanted to add that in now. So I imagine hopefully things are continuing to improve and get better.
I would hope so. Hopefully some changes maybe occurred after I left. So let's hope so. There are a number of women still on faculty, so either they're a lot tougher than me, or they did make a few changes. So,
well, Amy, I think
anyway, hopefully.
I think you make an excellent point. Oh, go ahead. Sorry.
It's okay. It's with our internet connections, it's hard to sync up a little bit. For our viewers, I will just say, and the other 2 guys are going to share this, Amy Alderman is an exceptional plastic surgeon. And in many ways, I felt as though when we were going through training, Amy was a year ahead of me. I felt like you were better than so many other men that were there. And in many ways, that sort of set the trajectory to where you're at right now. Do you feel like, particularly at the time that you were training and as an early faculty member, you were held to a different standard than a male plastic surgeon? Because there were many men that didn't measure up to you, and you're too humble to say that. But did you feel like you were held to a different standard as a female plastic surgeon in a specialty that's largely been controlled by men?
Guys, me, I'm really competitive. Y'all, before the show started, you talked about seeing my Peloton posts.
Exactly.
It's just me. I'm competitive. So I want to do the best I can do. I do think in a field that has been predominantly male dominated as a woman, I think that we have to really knock it out of the park. And like I said before, I would never want an opportunity because I was a woman. I want the opportunity because I'm the best person for that job, position, leadership role. So we'll just leave it at that. How about that?
Fair.
Yeah, I really want to echo what you said earlier about the work-life balance, and that's critical for anybody, male or female. And, I clearly find myself struggling with that constantly. I mean, I have 2 young kids, 9 and 8, or 9 and 7. I can't even remember their ages. That's how. Yeah. but it's a huge challenge as a parent and as just even a person to not kind of get on the hamster wheel and keep going and going and going without taking time for yourself and taking time for your family. So, it's an excellent point that you make. So.
And it's a little bit different in private practice versus university. The university, it's a little bit easier to take time away. You've got people to cover you. You've got a certain number of days off. And at Michigan, we were salaried. So if we worked more, we didn't actually, bring out more money. So it was a little bit easier to get away. But when you were there, the demands were just intense where it was very hard to make it home before, your kids are in bed. Private practice is a different challenge. I can make it home, but it's hard to say no to patients. So if a patient says, I really want this procedure and I need it done, you feel this pressure that you need to provide the service for the patient. And then it's easier for that to creep into your family life. So
at least you get remunerated for it, though.
Yeah, absolutely.
that does make the pain a lot better.
Well, Amy, thanks so much for chatting with us here. And now, we're gonna highlight some of your exceptional surgical expertise here. So, why don't we let you share your case, and so go ahead and share your screen, and let's talk about what kind of awesome work you do here.
So I thought I would just talk quickly about a really kind of simple concept, but and I bring it up because it seems like there's a little bit of a trend for, at least where I am, for smaller breasts, smaller augmentations, and I have a lot of patients that just don't want an implant at all right now. We see a lot of patients that want their implants removed. So I bring this up as a kind of an interesting idea or concept for a patient that needs rejuvenation of their breast, but they don't want an implant. And I call it a mastopexy with an auto augmentation. I had more pictures to show, but they didn't have hearts over the little nipples. So we're going to keep it at that so that we don't get in trouble. So the concept is, when you evaluate a patient, right, we're looking at what the upper pole of the breast is doing to help a patient decide, do they need an implant or not have an implant? And the only way to make a significant change in the upper aspect of the breast and the volume is to add that implant, like you guys know. And then the other concept is that this tissue that's hanging below the fold, we need to do something with it, or it's going to want to relapse and start to hang over the fold over time. So this tissue down here, if a patient is pretty large, I'll remove it, kind of unweights the breast, helps us get a longer lasting lift. This patient would be an ideally would have an implant. I think the three of you guys would agree. She's pretty volume deficient. She doesn't have much projection up here, and she's a little bit relaxed, but not super relaxed. She absolutely did not want an implant. So I'm trying to figure out, how do we get a little bit more projection behind the nipple when we can't put an implant in? So here's where the auto augmentation comes. So this tissue down here, where we don't want it, we use it and tuck it up behind the nipple and kind of tack it to the chest wall here, and then do her lift. So unfortunately, I can't show you the side picture because that one doesn't have the little hearts over the nipples. But if I could show you a side picture, she's got really nice projection, like right behind the nipple, that she didn't have prior to the mastopexy. And that's from this lower pole tissue being kind of turn it into a flap, flip it underneath the breast, tack it to the chest wall, and then do the lift as usual. So just bring it up as a nice concept for somebody that needs to augment behind the nipple, upper part of the breast, and doesn't want an implant. The auto augmentation is a good option.
So Amy, you're basically making much like a inferior base pedicle for breast reduction, but leaving the nipple attached to the upper pole and then tacking this underneath the breast?
That's absolutely right. So it's a superior medial pedicle. Here, it was just a superior pedicle because she didn't need to be elevated very much. If she did, you could just do a superior medial pedicle. The blood supply to the flap is deep right here. It's around the fifth intercostal perforator. And so that tissue that you would have as a traditional inferior pedicle, you deepithelialize it, take off the skin, and then dissect down around it. And you have to release it in all 4 dimensions. So you have to release it all the way to the chest wall here, up top, the sides, and along the fold. Then this part gets lifted up and you just tuck it up underneath the nipple.
That's a really nice result, Amy. How do you hold that tissue in the upper pole for a long period of time afterwards? Like, what do you do to sort of to secure that?
Well, so it's interesting because I've talked with I learned this from Dr. Betsy Hall Finley, and she told me that that tissue won't scar down to the chest wall, and that it will always be a little bit loose. But I'm not sure that's actually true, because I did go back in on one of these a year later. She's like, you know what, this is great. I want to go ahead and be bigger. Let's put an implant in. So it gave me an opportunity to go back in and see what that tissue looked like now that I was going to do an augmentation. And it did heal around the parenchyma. It wasn't like you could see it as a distinct flap anymore. It was incorporated. But in the short term, I just take a 2O PDS. On the top part, I do 2 sutures and just parachute them down to the chest wall. But it's interesting. It's very powerful what that tissue can do. So before I do the final closure, I tack the flap down on both sides, and I sit the patient upright and make sure that flap is located at the same position on the chest wall. Otherwise, you'll get some asymmetry in your projection.
So this flap is inferiorly based?
Correct.
Okay, because I remember seeing a superiorly based auto-aug type of procedure with Grotting. Dr. Grotting.
He flips it underneath.
Yeah, where he flips it underneath.
Yeah.
And I've done that a bunch of times. I've never actually thought about doing it from an inferiorly based perspective, but that would be a good idea too.
It's really easy. It's a really robust little perforator right at the base of that. But the key to get it to move up is you do have to dissect all the way down to the chest wall on all 4 sides of the flap. And then it actually elevates pretty well.
Do you use any mesh in any of your mastopexies or no? I
don't. I have, I really, in the last 10 years, I've only had 2 cases where I've used mesh. I'm thinking about it more in the massive weight loss patient. If you look at them and their fold is really mobile, I think they're a total setup for an inferior malposition over time. So I do have a case where I use Galaflex, and boy, that has held tremendously. So I think that would be the patient I would think about doing it in.
And do you ever use any? Sorry, Sal, go ahead.
So, Amy, I was just going to say, so this is really designed to increase lower pole projection, correct? Not necessarily upper pole projection, correct?
No, it's designed, that flap is really sitting at the nipple and about 2 to 3 centimeters above the nipple.
Do you ever?
And it's pretty much removed from the lower pole and advanced up. So it's really projecting. The projection is like behind the nipple.
Do you ever do auto augmentation with fat transfer to the upper pole? What are your thoughts on fat transfer?
I'm not a big proponent of it right now. I did a lot of it when I was at Michigan for the breast cancer patients. The problem is you can get a lot of oil cysts and changes to your mammogram. I talked with a local radiologist a couple of months ago about what changes she sees in the breast with fat grafting. And, it does really distort the architecture. So for my cosmetic cases, I don't do much fat grafting. I'm not saying it's a wrong thing to do. I just, if it changes their mammogram and it leads them to have like increased biopsies or imaging, it's kind of you can't reverse that. So.
Right. Well, that's a great case, Amy. I mean, just exceptional projection here. Yeah, obviously without the side view, but you can clearly see the lower pole of the breast. And just with the shadowing effect on this photograph, you can clearly see how much intended lift and how much extra projection you got. So great result. Really nice.
Well, thank you. And I think, again, she would have looked great with an implant, but it's a nice option for patients that want to don't want to increase their breast size and don't want an implant, but you need to. Betsy Hall Finley is the one that taught me this, that you got to remove the tissue where you don't want it. And so, that lower pole tissue there, either get rid of it if the patient's large, because it's going to kind of unweight the breast and allow you to reshape them better, or move it like with the auto-aug and put it kind of where it's going to benefit her cosmetically.
Now, Amy, a couple times now you've mentioned Betsy Hall Finley, and I know just from our friendship throughout the years, she is a huge mentor to you. Tell us a little bit about your mentorship with her, and just what inspired you about her, and kind of maybe talk a little bit about your relationship today. I think that's important for our viewers to hear.
I will, and I'm trying to you guys know how I can stop the share the screen so I can see you again.
Let me call AV support here. Sam Marie.
Here we go. Is that better? So Betsy Hall Finley is, I think, just an amazing pioneer of breast surgery in our time. She's in Banff, Canada. And, I was trained, like all of us at Michigan, to do breast reductions using the traditional anchor or Weiss pattern, where there's a big incision along the fold. And right out of training, I went and spent some time with her and learned how to do her vertical breast reduction. And there's pretty much not a breast surgery I do now that's not influenced by what she taught me. So I'm almost 99.9% a vertical pattern, whether it's a reduction or mastopexy. And she's amazing. She's 70. She turned 70 this year, and she still operates 3 days a week and works 4 days a week, and is going strong. So one really neat thing was over COVID, when I couldn't operate, I called her and I said, will you review my cases? And it's very humbling to have the person that taught you how to do a procedure review your cases. But I picked, I may have picked one of my best ones just to show off, but I picked a lot of my ones that I thought could have been improved. And so she spent 2 hours with me on the phone, kind of going through what she would have done differently. And I learned a lot from that. But you have to be a little bit humble to go through that process, but it was good.
That's great. Well, gents, any additional questions for our wonderful guest here?
No, it's just amazing. After has it really been 20 some years? You've gone through so many different iterations of what you've done. You got through academia all the way up to full professor. You've done a tremendous amount of research at the institution. To stay at an institution means they thought you were basically better than anyone, that they wanted you there. They wanted to keep you there. They saw the talent. They saw you up close and personal. It wasn't an interview. It was multiple years of watching you work that determined whether or not they wanted to keep you there. And you progressed basically as far as you could go, or you chose to go, basically. And then you remade yourself. You're still remaining in academic plastic surgery as part of the board, and you've basically built your life exactly the way you wanted it. And when you look back at it, is there any regrets, anything that you feel like, you know what, I really didn't, maybe I should have done this instead, or taken this opportunity, or something that you feel like?
I really think you shouldn't live life thinking of regrets. And so there are definitely aspects of different jobs I've had. I left Michigan, I was actually an employed physician. So I was 8 years of a practice and I was employed. And then I left that, started my own practice. So I have kind of tried about every different model of practice you can have. And instead of thinking, boy, that was a horrible experience and I regret that, I think it's better to think of, boy, I learned a lot from that, and let me take that and then figure out how to make the next chapter better. So I loved my time at Michigan. I learned a lot. I enjoyed my I still am quite good friends with a lot of my colleagues back there. And so I don't regret that. And it did kickstart my career. I did have people tell me once I left Michigan, my career was over. So it's pretty nice to prove them wrong. And it was fine to be an employed physician for a while because my kids were really young. And so I didn't have to worry about how to manage a practice. But then there comes a time where you want to have more input on how the practice runs, and you want the practice to reflect your values. So now it's fun because I'm learning a little bit about how to run a business and how to manage employees. And so that's just keeps life challenging every minute. So it's all good.
So what are your future goals? What are your future challenges? What do you look forward to doing now as your next step?
Yeah, well, I'm really excited to last year, I got on as a director for the American Board of Plastic Surgery. And I'm just, to me, that's like my personal biggest position or honor I could get. I think board certification is really important. In Atlanta, for example, we have a lot of physicians practicing cosmetic surgery that are not board certified plastic surgeons, and patients are getting hurt. So to be able to have an opportunity to help with our board certification and our profession is probably the most important thing I think I'll do in my career. And hopefully we can continue to get the word out to the public that board certification is really important. And it doesn't matter if you're having a simple liposuction case or a more complicated procedure, you want to go to somebody that's board certified in that procedure. I think we could all agree with that. And then the other thing is I just got to be co-chair of the Atlanta breast meeting. So that's nice because it's in my backyard, and it's the part of plastic surgery I love the most. So I look forward to being involved with that meeting. I know Sal and I are both, sorry that we lost Dr. Mark Codner way too soon. He was a leader with this meeting, and before he passed, he had asked me if I would be interested in getting involved with the meeting. So I'm very thankful that he kind of opened up the door, and will do my best to kind of help shape the meeting in the future, how I think he would foresee it to be shaped.
Well, Amy, as always, I've learned a lot. Yeah, from the case that you presented. You presented it so humbly and so simply, but it's a great idea, a really, really nice result. And I can definitely speak for the other two when I say we're seeing a lot of patients who don't want implants. That's a really nice option and a really nice result. So thanks for sharing that with us.
Yeah, thanks for having me, guys. It's good to see y'all again.